I agree with a lot of the points Kerry has raised, but we probably do come at it from a slightly different perspective. I work in a cancer hospital. We have a program of supportive care, physicians, nurses, social workers, psychologists, psychiatrists of all kinds, who care for people with cancer from the beginning to the end of life, including in our palliative care unit, including in our hospice. I've been on many discussions like this, and in various forms, panels, media, and so on. And I must say I find a disconnect, however, between the work that I'm involved in every day and what goes on in the press and the media, because you would believe that this was the main problem for people facing the end of life, wouldn't you? Considering how much press, including in today's newspaper, there is. It's actually not. And we could ask the question, why is this problem emerging now? Does anyone have an idea about that? Why are we so concerned about this problem now? And why is it occurring in Western affluent countries? Right? It's partly the demographics. It's not a problem of developing countries, of lower middle income countries. It's a problem that's emerged in more affluent countries where people like ourselves are accustomed to personal control, to having control over our own destinies. And as we grow older and as we become ill, we now face this terrible realization that, in fact, no matter how rich you are or how influential you are, that we're all in the same boat when it comes to illness and disability. And you would think from the press or from many discussions that it's about relieving unbearable pain. Do people think that's the case? No, it's not, actually. Almost always not. We're actually pretty good at relieving physical pain. It is about personal control and vulnerability. If you watch the Don Lowe video, and I know Don Lowe, I knew Don Lowe, I know his wife, he said, why can't I control the circumstances of my dying? He said, I don't actually have pain. And by the way, Don Lowe died 8 days after that video was taken. And one could ask the question, even if one is in favor of assisted dying, at what point should his life be taken? Before that video was taken, or in the first, second, third, or seventh, or 8th days after the end of life? It's not at all clear to me. The main problem in the treatment of cancer, actually, in the Western world, is over-treatment. People get aggressive treatment more than they should. In fact, there was an interesting study in Boston, it got a lot of press, it was published in the New England Journal, which showed that people who got early palliative care lived longer than people who didn't. And the reason was, actually, they got less chemotherapy. Chemotherapy, when you're very ill, chemotherapy at a certain stage can be very helpful and can prolong your life. When it's given to people with the disease that's too advanced, it actually shortens their life. And the reason they do it is that patients want to live, and doctors have a hard time not responding to that issue. So that on an everyday life, what people want to do is live longer. In countries where it's available, do people know what percentage of people, like Switzerland, Holland, several states in the United States, do you know what percentage of deaths occur as a result of that? What percentage of people take advantage of it when it's available? Anybody have an idea? Anybody take a guess? How many? Anybody have a wild guess?
0.5%.
How many?
0.5%.
It's about 3%, 4%. And it's equivalent, most of you probably plan to stay for the evening here for this discussion. But what if we said, you know what, we're locked the doors, you can't leave. You would all of a sudden feel uncomfortable and want the door to be open. And so that when you do surveys, the vast majority of people want this to be available. The vast majority of people do not take advantage of it. So it's about personal control. Now, the issue is hard. I was a bit nervous about the idea of debate, because the idea is actually hard to debate because there's certain bedrock views. Some people feel that people have the right to have personal control over their life, and other people feel that the taking of life is wrong, period. And those positions are actually hard to debate because they're quite fundamental. And we probably find ourselves in this gray position, in the middle. But I was reminded, my wife will remember, our daughter gave before I was as involved in this, she gave a talk in grade 8. She's now in her late 20s on this subject. And her opening line was, "Murder is always wrong." Or is it? That's the question we all face. Now, everyone understands that physical pain, or many people understand that physical pain is something that can be treated. But when people say that to protect my dignity, I must end my life, what do we think about that? Do we think that the loss of dignity is something that requires us to end life? Now, it's an interesting question because anyone know what dignity is, by the way, what the definition of dignity is? We all have a feeling about it, but anybody put some words to it? Dignity comes from the Latin word dignitas, which means worthy. And the loss of dignity has to do with the loss of self-worth. Now, when any of us, not just have a terminal illness, but when we become older and are less physically strong and our physical appearance changes and we're no longer able to work, we all feel a threat to our self-worth. Is the loss of dignity something that can be treated? When people feel a threat to their dignity, is this something that we ought to be able to help them with? Now, by the way, this is something we do in the hospital. We do it in several different ways. We do it by treating their physical symptoms so that people don't have unbearable pain and physical suffering. And we do it by treating the psychological consequences of disease. You know, someone's done they did a large survey in Sweden, 6 million people, and they looked at suicide rates in people who develop cancer from the beginning of diagnosis to the end. When do you think the suicide rate is the highest?
Beginning?
No. Why?
Loss of hope.
Pardon me?
Loss of hope.
It's fear. Loss of hope, fear. It's not due to physical suffering. If it was due to physical suffering, you'd expect the suicide rate to be higher as they got sicker over time. So that's a fear that we can treat. My research group, actually, unbeknownst to me, came here tonight, and they know we're involved, actually, in providing early palliative care for people in our palliative care team to relieve physical symptoms, to provide support, in intervening psychologically to help people face the loss of physical capacity, the fears of dependency, the fears of vulnerability, having to depend on other people. Those are problems we think we can help, and actually most people want to continue living as long as possible. And palliative care is as much or more about helping people live as it is about helping people die. And one of the most touching moments that we've had, and it's not rare, is marriages in our palliative care unit. It's a very moving moment when people get married. We've seen that. Because there's nothing like the shortness of life that makes people more aware of what is important in life. Now, population, I don't think this is something that can be decided narrowly medically. It's not a medical question only about whether helping someone take their life should occur. It's something that does have to occur by debates in the population and in our legislatures. I think it evokes a lot of interest because of the ethical, legal, religious questions that it involves. It's, in my view, and I'll make a provocative statement, it's a misplaced emphasis. It's not the main problem. It's not the main solution. If it is legalized tomorrow, it will not help 95% of the people who are terminally ill. What we need is better palliative care, and we need it from the beginning. Governments are starting to recognize that. We have much more funding than palliative care, but I'll tell you, we opened a residential, with Kensington Health Center, we opened a residential hospice where people can have medical and nursing care, but in a home-like setting. It's about a third the cost of what it would cost to be in a hospital. This is for people who it's not possible to be at home when they die. And the Kensington Health Center went way out on a limb by funding this, and they put in about $7 million in renovating the derelict chapel, and they put up $1.3 million a year. And we spent the next 2 years trying to convince the government that they ought to fund it. Even though it fits very much with provincial government funding, and only recently actually have they funded it. This is much more important to me about this kind of resource being made available to help people die well than this question, as provocative and controversial as it is. Thank you.